welcome to episode 6 of From Paper to Clinic. I'm your host, Dr. Hamza Shah, and today I'm excited to be joined by Dr. Andrew Rixon. Dr. Rixon is currently an attending optometrist at the Memphis VA Medical Center and also a consulting faculty at the Southern College of Optometry. He's a fellow of the American Academy of Optometry and a diplomat of the Academy's glaucoma section. In addition to his clinical work, Dr. Rixon is a frequent lecturer, author, peer reviewer, and educator who has made significant contributions to the field of glaucoma and optometric education. Dr. Rixon, thanks so much for coming on the show.
Yeah, Hamza, I really appreciate you having me on, and just let everybody know. I first met Hamza up when he was doing his residency. I went to hang out, and he taught me a bunch of stuff. So he's a killer. He's really good. So I appreciate
Well,
you having me on.
well, you've taught me a lot as well, so I appreciate that. Today's publication is called Retinal Biomarkers for Early Alzheimer's Detection, a systematic review of optical coherence tomography findings by Marin, Lepoitman, and colleagues. Dr. Rixon, dementia and Alzheimer's often get used interchangeably. Can you clarify the key differences there?
Yeah, this actually came up in clinic yesterday, and it was something that I was actually guilty of with just, oh, they have dementia and not really understanding what that meant. So I had a student that came out and said the patient can't see as well and they have dementia. But in prepping for this, realizing my ignorance, dementia is just a huge umbrella term, like dementia, glaucoma, AMD. It's like, what are the subsets within there? So, dementia is literally just, clinical symptomology, where you essentially have a patient that is having declining cognitive function, and there's different cognitive domains. And there have to be at least like two cognitive domains that are affected. It has to be progressive and it has to have reduction in functionality. And that's what discerns it from like mild cognitive impairment. When you look at Alzheimer's, Alzheimer's is a type of dementia, right? So there's multiple forms of dementia that can end up with similar clinical picture, but there's different pathophysiology. And so from Alzheimer's, and what we'll be talking about that is what it's doing is you're ending up having a buildup of beta-amyloid deposition in the neuronal synapses. And then you also have just that neuronal cell body ends up having tangled up by phosphorylated tau. So again, one is a pathology that results in clinical symptomology. And it's important to discern. And in talking to that student, I was like, well, what type of dementia is it? How advanced is it? And, what was done on this? Did you look at neuropsych? And the guy ended up just having dry eye. It's just so we have these biases on the front end based on misapplication of terms, and I'm guilty of it.
No, I think that's a really good way to put it. I think my simple way to remember it is dementia is the what, Alzheimer's is the why. And that, I feel like that kind of
That's a great
clicks
way to
in.
put it.
That clicks in. And the article went over, I think the nice thing the article did is it made the scale of cognitive impairment to
Yeah.
provide, what's severe and what's mild, starting off with subjective cognitive decline and ending with severe Alzheimer's. Where do you think we need to catch these patients, at least from the article's perspective?
Yes, from the article's perspective, I think this is, I don't know why I'm mirroring this to glaucoma again, but you want to detect things early, right? You want
Hmm.
to see which patients are amenable to treatment if treatment is available, and you want to get to that before there's cognitive decline. So, I mean, I think the Alzheimer's stuff, and there's different numbers out there, is that
Hmm.
you would have biomarkers that would be present, and you might have severe symptoms 10 to 15 years
Hmm.
after it was something that was detectable. So if you
Hmm.
could detect something using biomarkers before someone was having symptoms and you were accurate on those biomarkers, obviously what impact could you have on quality of life? So you
Hmm.
want to get to it as early as possible. I think that's what was great about this was they specified in the meta-analysis doing pretty much pre-clinical Alzheimer's and then very mild cognitive impairment and early Alzheimer's because that's where you'd want to catch most things from a deterioration standpoint.
At that preclinical Alzheimer's
Yeah,
disease.
absolutely.
And currently, from my understanding, I mean, we're catching people at that mild Alzheimer disease stage where they already have symptoms and they already have the biological markers. And I mean, the consensus is that's a little too late. Would
Yeah,
you agree? Yeah,
yeah, absolutely. But I think you also have to look at how powerful are the medications right now.
sure.
So I think almost like a lot of this right now is just prospectively can we detect earlier? Kind of like, when we started doing like with AMD, I know y'all did that before with the CAM
Hmm.
studies, and you're trying to label things early in the goal that you're going to have something that can treat it. So, maybe there's going to be better and better research out there. And so if we can detect better medications may do a better job. Because
Absolutely.
I don't think they're overly impactful right now based on what I've heard.
Hmm. Yeah, I guess that's all we got. The article mentions the retina to be considered as a window to the brain. Can you explain what that means biologically and how that may relate to Alzheimer's?
Yeah, I had to brush up on this because this is another one of those things that's like, you're applying to optometry school and they're
Hmm.
interviewing you and you're like, the eyes are the window of the body or something, you know what I'm saying? And they're like, oh, you got accepted because that was an amazing answer, which, obviously it's a canned answer. But embryologically, it's neuroectoderm, right? So both the retina and the CNS come from the neuroectoderm. So I mean, they're again brushing up on terms. They're homologous, so
Hmm.
they're very similar. And even you look at 2013, the American Heart Association was like, CNS tissue, retina tissue, it's exactly the same. So you have neurons in similarity, you have vasculature in similarity, you have blood retinal barrier, you got blood brain barrier, you got immunoprivilege. There's just so many similarities. In that it would make sense that you might be able to use non-invasively retinal information to try to
Hmm.
give clues about the brain.
And something interesting that the article mentioned was these amyloid plaques that you see with patients with Alzheimer's, they were found in the aqueous humor at levels comparable to cerebral spinal fluid. I mean, that was pretty surprising to me.
Yep.
Uh, and knowing that and knowing what we know about the retina and how that's influenced by Alzheimer's, I think we're looking at the right structure.
Yeah.
And so hopefully in the near future, we can get some technology that can measure things at a certain level where we're catching it early and getting these patients treated.
Absolutely. Absolutely. And I think they found tau protein, the phosphorylated tau in retinal ganglion cells. So,
There we
I
go.
mean, there's definitely some linkage there by
Hmm.
having to capture it, like you said.
Yeah. So our current diagnostic tools include positron emission tomography, cerebral spinal fluid analysis, some cognitive assessments, and genetic testing. But the paper is arguing we need something better. What's missing here?
I mean, what's missing is like the panacea, right? You go into some
Hmm.
sci-fi movie and you walk up to me, the doctor's pretty much replaced, the
That would
machine
be nice.
yeah, and that's like true personalized medicine. So I don't know, when you read, I mean, this is your podcast, right? So when you
Yeah.
read these articles, you see the conclusion a lot of times are, well, we have insufficient evidence based on this, but this is the theoretical, and we really hope at some point something would come around.
Hmm.
That would be obviously non-invasive because I mean, no one wants to say, hey, there's Alzheimer's in my family historically. I've not done genetic marking. Maybe I don't have the money to do that, but now someone's offering to do a lumbar puncture and see if I have amyloid, beta buildup in my CSF. I don't think anyone wants that. And then, you end up having the post LP, leak, and then you get a blood patch. And see, so these are invasive. When you're doing PET scans, you're doing relatively invasive, radioactive tracers. What's interesting was I was looking at the publication date, or at least when it was accepted. So there was a revision in May of 2025, and then
Hmm.
it was accepted maybe in like October, November. But in May of 2025, FDA cleared two individual blood tests. So they're blood biomarker tests that the Alzheimer's Association says if you get a certain reading on that, you may actually be able to bypass some of the more invasive PET scan and CSF. So I mean, I don't know what they would have said about that. I think they would have still said, "Hey, we need something that is super easy, cost
Hmm.
effective, doesn't touch you, and gives us all the answers," which just doesn't exist.
Yeah. Ideally, that would have been the OCT, but I guess we're
Yeah,
going to touch on
yeah,
that next.
yeah.
Yeah. Uh, when compounding all the results, I mean, this paper mentioned about 22 studies, and it seems like they're not entirely conclusive. For example, some studies show increased thickness and vascular density, others are showing decreased thickness. Are they both right? What's your final take?
Yeah, I mean the two may not be mutually exclusive, but it's theorized, right? So they theorize again if I have If I have buildup of amyloid, buildup of tau, then initially there may be an inflammatory response. So that might result in, I guess, retrograde thickening if we're saying the retina is retrograde, right? So you may have retrograde thickening that occurs that, you and I would not be able to tease out on the individual patient. And then, there's also some stuff, there's like cerebral amyloid angiopathy. So there's also vascular changes that can occur prior to. And so I think most of the more severe cases across the literature show thinning and reduction in vessel density, but you might have something first that's thickening, and then you might have something later that's thinning or less dense. And I mean, like you said, 22 studies, they were really heterogeneous.
Mhm.
There was a lot of flaws. Some really didn't have good biomarker stuff. Other stuff didn't even actually really vet that there was Alzheimer's. They had like mini mentals. And so
Mhm.
you can't just walk in and just, wow, I'm going to do an OCTA and I've diagnosed you with Alzheimer's. It's so much more complicated than that. And that would be irresponsible for us to do.
Absolutely. And I'm hoping, I mean, technology is advancing at a rate, I mean, faster than ever with the incorporation of AI,
Yep.
maybe OCT that can look at the cellular level, at the level of the cellular level. Maybe we can get something where you can just do a scan similar to that sci-fi
Yeah.
example you gave, and then boom, you diagnose someone with Alzheimer's.
No, no, I
But
mean, you guys are doing that adaptive optics down there
mhm.
with the primate research, and yeah, you leverage AI in there. Absolutely, like AI probably would do a better job, and AI would probably laugh at me right now, be like, "No, we can do that right
Well, let's move a little bit away from the article. Let's talk about just OCTA in general and how you utilize it
now."
in clinical practice. For the ones who may not be familiar, how does this technology exactly work? And does it replace your traditional based, dye-based retinal angiography?
Yeah, I mean, the first thing I would say is if you're not using OCTA, I do think it's another powerful tool that we have. I think in the last year, there's that 92137 code. So you do get
Hmm.
reimbursed. It's bundled with the 92133 or 92134. So you're not getting paid, you get paid a little bit more. I mean, OCTA, obviously, you're not having to inject dye into someone's arm or their hand. Or I had a colleague that had to do a foot one time.
Oh, wow.
Yeah, foot to retina time. I have no clue what that is. But essentially what you're doing is the machine is leveraging the optics. So what will happen is they will take sequential B scans, or the machine will take sequential B scans over the retina. And in principle, there shouldn't be anything overtly dynamic about retinal neural tissue, or, RPE as well. The only thing that might be dynamic is erythrocytes in the blood vessels. So they'll take sequential B scans, and if there's a difference amongst the B scans, the algorithm will post-process that, and the presumption is that difference is actually erythrocyte movement. So then you'll have different algorithms on different platforms, and it will ultimately provide you a brightness map that is the machine's rendering of what erythrocytes might be doing at that 2 or 3 millisecond time. So you're getting a snapshot. You are not getting real dynamics that's going on, like you would with fluorescein angiography. So has it replaced fluorescein angiography? No, because we now know more about peripheral changes, especially in diabetes. So to me, we've shifted the model away from fluorescein angiography in posterior pole to, periphery using ultra wide field, and then doing more OCTA, central. The drawback with OCTA is, again, depending on the platform and ultimately the field of view is limited.
Absolutely. And yeah, I was reading a couple case studies the other day, and you wouldn't catch non-occult or non-exudative occult membranes on the retinal angiography. For something like that, you would only catch it on OCT. So I was like, well, I guess they both have their own applications. You can't replace one with the other, and they both kind of exist in their own place.
Yeah, I think completely, that's a good way to put it. I think most of these things can be complementary. Uh,
Hmm.
and if someone's asking me like, oh, is this dead? It's like, no, there's still probably some application. You just have to be aware of it, and you still have to have the skill set. I mean, you could do ICG, but I mean, that's another, that takes a while, and,
Hmm.
it's piggybacking off the die. So we really don't do too many ICGs anymore, because you're right. Why would I do an ICG, or even have to get a fluorescein in the first, 12 seconds, if I'm running it by myself in order to do it, if the OCTA can do that?
Absolutely. When do you most often use OCTA in practice?
Yeah, you hit on it. I mean, you're looking for non-exudative macular neovascular membranes, right? So
Hmm.
SIRE is a term that's very specific that is a double layer sign. So essentially you have dimensions. So the double layer sign occurs when you have Bruch's and you have RPE, and then you have typically something heterogeneous from a reflectivity standpoint, like a mixed reflectivity thing. That's called a double layer sign, or it's shallowly irregular RPE elevation, but you don't need to use that. So if you see a
Hmm.
double layer sign and you see no subretinal fluid anywhere, what you want to do is you want to do OCTA, and
Hmm.
OCTA may pick up a net, but that net is quiescent, so it's inactive, it's not leaking yet, and then you can go ahead and figure out what intervals of care, because the standard of care is not to inject at that point. You're not going to start, shoving needles intravitreally and taking on some risk for something that's not proven. But that's the main application for me, for OCTA, and then some diabetes and some glaucoma, depending on the individual situation.
Do you ever consider doing like a baseline OCTA on patients rather than waiting to see something on your normal OCT and then doing an OCTA?
Just as across the board.
Just yeah, like your AMD patient that comes in and you see some drusenoid
Yeah.
PEDs that are maybe a little bit larger and your gut kind of gives you the wrong feeling and you're like, you know what, I'm gonna start doing baseline OCTAs on my moderate AMD patients.
I think you hit on the most important thing. Is It's like, what is the clinician's inkling, right?
Mm,
So there are certain phenotypes that I'm going to see on my cross sections that will make me say, yeah, this is sketch, or the
mm,
clinical term, but like there's something I don't like about this. And so there may be circumstances where there's some confluence of drusen, but it's got some atypical appearance. And it's like, yeah, let's go ahead and do an OCTA on that. It doesn't necessarily have to be the double layer sign. And a double layer
mm.
sign is not ultimately the most prognostic, thing, but it gives you a much greater hit. So even if the hit rate's 10 to 25%, depending on what I'm saying, in most cases, you'll see a double layer sign and there won't be a net. I think, are burdened on doing that, or you're obligated to do that. So yeah, I think it would depend on the circumstance.
Okay, but not like every moderate AMD patient. I got
No,
you.
because it would have to have certain care. And so, like, again, you look at
Sure.
intermediate AMD, we're talking about umbrellas,
Hmm.
intermediate AMD. So that could be, oh, I have, one large drusen,
Hmm.
or I could have a ton of RPD. I could have 30 large drusen. I could even have
Hmm.
Aurora in that, because that's not really in a classification, right? So my spectrum there is broad. So just doing OCTA, of the central area there, I guess we'll call it just the central macula there. It's like, what's the positive predictive value of you just doing that?
Hmm.
I don't think it's high. You could do it. I just don't know what
Sure.
your yield is. And then, are you adding an additional piece of information with a technology where you're imaging the living, and you have to have a good skill set in the analysis, and then you misinterpret, so I don't know what the value of that would be versus, having individual circumstances that you are reacting to. But you could do it. I mean,
Yeah, no, that's fair. No, like, treat it as a reactive time. I mean, it is a little bit more expensive. So, and does require a skilled technician to do it. The patient has to be super still. If they move a little
yes.
bit, you get, false positives in there. So, we want to use it when we really need to.
Yeah.
Since you're the glaucoma expert, have you started using OCTA for glaucoma?
Yeah, it's a good question. So your residency supervisor, Dr. Lefert, and I, and a couple, Derek McDonald and Mike Simber, we did an OCTA and glaucoma lecture like 5, 6 years ago, and we were calling it, OCTA and glaucoma. Is it a disruptor, or is it just a distractor? And we concluded
Hmm.
it was a disruptor. Um, I don't use it that much. And part of that is the fact that the platform I'm watching my glaucoma patients on does not have analytics. So it has angiography capabilities as far as OCT angiography. And so the other machine that has analytics is down the hall. So I'm not going to be tracking off that. There are circumstances there I might do OCTA, and again, it's theoretical. Like on cases, like the few cases that I have that might actually be like an NTG, like a true NTG phenotype, where
Hmm.
cold hands, sleep apnea, um, you know, migrainers, all this other stuff, low blood pressure if you're doing a 24-hour ambulatory and, in-office IOP because you can't, I'm not doing eye care at home over at VA.
Hmm.
It was extremely low. Maybe I do that, and maybe I say, oh, is there any possibility that this is showing lower than average vessel density? But there's not a normative database on low vessel
Hmm.
density. So, what I will tell you is that in theory, from a vascular functional or OCTA to visual field correlation, that's actually supposedly a stronger correlation than is structure function as far as OCTA perimetry. So I think it is useful. I have colleagues that they use that platform for everything. So they're doing the OCTA baked in. And I think, prospectively, this is kind of like the conversation about OCTA and Alzheimer's is, there's been a couple of publications out about, okay, I go ahead and do OCTA and then I treat. And so it may be that I treat them, say, with Notarsidil, or I treat them with latanoprost, and maybe the vessel density improves beyond noise, and that may be a biomarker for us actually having successful treatment and more personalized medicine. But that's still,
Hmm.
it's not something I can just say, yeah, you can do that right now.
And we're missing that normative database. It'd be nice. I
Yeah.
mean, it'd be nice if we had something like that. So certainly looks like that there might be something there, but I think we're still in development for
Yeah.
glaucoma. That's what it sounds like.
Absolutely.
Well,
I think there's potential.
mhm.
Yeah.
Well, I think that was a good question to end on. This wraps up episode 6 of From Paper to Clinic. Dr. Rixon, it's always a pleasure listening to your expertise.
Great. Thanks so much, everyone. And thanks for having me on, Dr. Shah.
Episode 7 will air in the first week of August, featuring Dr. Leonard Mesner, and we will be talking about idiopathic intracranial hypertension. Thanks for listening, and I hope you'll join next time.